Hello.
Hi. Hello, Dr. Sachin.
Hi, how are you? Just one.
Fine, thank you.
Hello everyone. Hello.
Hi, how are you?
Yeah, good.
Hi, how are you? Don't worry.
Good evening and good morning.
Hello, everybody.
Yes. Hello, Dr. Chan.
Hello.
Hi, good evening. Good morning.
Yeah. Hello, everybody.
How are you?
Hello, good evening.
So Sachin, are you well now?
Yes, I'm better. I'm fine now.
Okay, you admitted to the hospital.
Yes. I think
I'm very sorry. It's bad for you. But now it looks nice.
Sachin, are you here? Your image is frozen.
Hello.
Hi,
I can hear you.
Hello.
Dad, how are you? Konnichiwa.
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 Hello. How are you?
Can we have the Kishida Sensei?
Yes, here.
Sachin, how are you?
I'm
Sensei,
really pretty good. Konbanwa. Hello, everyone.
Hello. Hello, Sachin.
So I think it's 7. So Sachin Sensei or Dr. Liu. So shall we start? Dr. Liu, shall we start?
Yes, Prof. But Professor, yeah, Professor Hugo is here. I think we have four here. Sachin, can you moderate the session for Sachin?
Yes. Am I audible clearly?
Yes.
Sachin.
Yes, Sachin.
Okay. Very good. So first of all, good morning, good afternoon, and good evening to all the friends. I welcome you on behalf of ACNS YNS committee for this yet another interesting webinar, which we conduct on every second and fourth Sunday for the whole sole purpose of education of young neurosurgeon. So I welcome you all again today. So today we have an interesting session where we have Professor Hugo Kishida as our chief speaker and Dr. Sam Joye from Malaysia as a YNS speaker. Our chief patron, our president, Professor Yoko Kato, is there to support us as always. To chair today's session, we have Professor Yurian Masabellu, and the discussion for today's session is Professor Alexander Wozniak, who's the president of Ukrainian Society of Neurosurgery, and Professor Fawad Pirzad, who's the president of Afghanistan Society of Neurosurgery. To moderate with me, we have the co-moderator, Dr. Ben NG from Hong Kong, Dr. Heba from Egypt, Dr. Atik Islam from Bangladesh, and Dr. Karimov from Uzbekistan. So I would request Dr. Ben to kindly introduce our first speaker, and then we'll start. Dr. Ben?
Yes, hello.
Yes.
Can you hear me?
Yes, we can hear you.
Yes, I think we should let the chair today will be Professor Arian, and I think we should invite him to speak a few words and to introduce our first speaker.
Dr. Ben, thank you very much. It's an honor for me to have that pleasure. So I'll go on and introduce our first speaker, Kishida Sensei, who's an MD, a PhD with a degree from the Aichi Medical University, a physician who earlier in his career joined a very famous center of neurosciences in Japan. It's a Japanese Red Cross, the Nagoya Daini Hospital. Dr. Kishida then moved on to the Aichi Cancer Center Research Institute for a period of about 3 years. He completed his PhD degree at the Nagoya University, another world-renowned center. It's just a friendly reminder. It's there where Dr. Sujita, the very famous Dr. Sujita, practiced neurosurgery and introduced the world to the techniques of open vascular surgery. He then joined Fukushima Medical University as an assistant professor. And from 2016, Kishida Sensei has been a deputy director of neurosurgery at the Japanese Red Cross in Nagoya Daini. And from 2023, Dr. Kishida is at the Tokyo D-Tower Hospital, a very well-renowned center of neurosurgery and neurosciences in Japan. It gives me a great honor to be together here, and I guess I wouldn't be able to call myself a chair when I am here present together with Dr. Wozniak and Dr. Pirzad, so I better call myself a co-chair along with other colleagues. And with this great honor, I will give the turn to Kishida Sensei, who is here with us. Kishida Sensei, arigatou gozaimasu. Thank you so very much. Thank you very much for being here with us, and I will let you go with your presentation on keyhole approaches and uses in neurosurgery. Thank you.
Thank you very much, Mr. Chairman. And hello, everyone. Nice to meet you. And thank you so much for inviting me to your conference. I appreciate valuable opportunity. Okay, I will share my presentation. Is it okay?
Yes, we can see your slides. Yes, now it's perfect.
Thank you.
Yes.
Okay, let's start. Today's my theme is endoscopic keyhole surgery for intracranial tumor. I introduce myself again. I am Dr. Kishida, neurosurgeon of Tokyo D-Tower Hospital in Japan, in Tokyo, Japan. I'm specialized in neuroendoscopic surgery, such as endoscopic keyhole surgery, endoscopic endonasal scalpel surgery, transtubular retractor surgery, MVD, and so on. Today, I will make a presentation about keyhole surgery for intracranial tumors. First topic is the concepts of endoscopic keyhole surgery. So why do we use an endoscope instead of a microscope? To consider this question, I have summarized the problems with microscopic surgery through a small craniotomy. The largest problem of microscopic surgery is blind spots in deep area. Professor 𝒂𝒂𝒂𝒏's group reported about endoscope-assisted microscopic surgery in posterior cranial fossa. They say that high frequency of tumor remnant was observed by endoscope after microscopic tumor removal. So after microscopic tumor removal, very, very high frequent. And traction injury is also a large issue, not only brain contusion, but avulsion injury of cranial nerves or bridging veins are often occurred, you know. Furthermore, patient's position and head rotation are restricted by the optical axis of microscope. Prone position put a cardiopulmonary strain for elderly patient. Lateral or park bench position have a risk of pressure ulcer and sometimes peripheral nerve disorder. And then physical stress of surgeons are also be greater. Surgeon and assistants physical stress is very strong. So to solve these issues, we aggressively use endoscope. The most significant objective is to improve visibility and to reduce blind spots in deep portion. Microscopic view through a small craniotomy tends to make blind spots in deep area, and most neurosurgeons feel it dangerous. Sure, I also feel it dangerous. Therefore, when we use microscope, we generally make a large craniotomy and move our optical axis or drill out the bone at the skull base region to eliminate blind spots. On the other hand, the viewpoint of endoscope is inside the cranium. We are able to obtain close-up blind view with wide viewing angle, even in deep portion. Large craniotomy for observation is not necessary because we can change our optical axis just beside the lesion. This is, for example, this is an endoscopic view through a keyhole craniotomy. This is the case after removal of crinoidal meningioma. The medial and inferior side of the ipsilateral optic nerve are easily observed by the use of endoscope. Generally, here and inferior side of ipsilateral optic nerve is difficult to observe by microscopic surgery. Second purpose is minimization of traction injury of brain and surrounding tissue. The straight optical axis from extracranial viewpoint of microscope, we tend to compress the brain or surrounding tissues by retractor or surgical instruments. Wide viewing angle or oblique view of endoscope is just like a bird's eye view, like here, bird's eye, like a bird's eye look down viewing. And it leads to avoidance to excessive compression to surrounding tissues and brains. And I often use slightly curved instruments to reduce brain compression more. Other advantage of an endoscope is less restriction of optical axis, patient's position, and surgeon's posture. In endoscopic surgery, we are able to change an optical axis easily, even horizontal or look up direction, because endoscope is small and easy to handle. In this photo, endoscope is put almost vertically, but surgeons can operate in a relaxed posture with watching the display. This style is called heads-up surgery, characteristic of endoscopic surgery. This is an interesting example case. Solitary fibrous tumor extending to scapula and infratentorial region. How are you going to plan surgical position or surgical setting for this case? That's very difficult, I think, by microscopic surgery. Maybe most neurosurgeons plan staged surgery, transtentorial occipital transtentorial approach, and removal of supratentorial tumor, maybe. But my answer is very simple. Just prone position with horizontal head posture. In this case, we prepared 2 displays, and we positioned the caudal side of the patient in the first half of the operation, and moved to cranial side after finishing the resection of supratentorial tumor. And after that, I also changed sometimes. Gross total removal of the tumor by single surgery was achieved. Actually, we have little opportunity to place a patient semi-prone, lateral or park bench, sitting or concord position now. Most of these positions can be changed to lateral supine position with head rotation or very simple prone position. Next, I will explain about surgical setting, actual surgical procedures, and illustrative cases. This is our surgical setting. We use a floor standing type endoscope holder called UniArm, which is a Japanese product and securely fasten any endoscope. Heads-up surgery with both hands is performed, and we call scopist assistant doctor who manipulates the endoscope by himself. Role of scopist is very important in our surgery. Scopist manipulate the endoscope during the surgery to avoid the interference between endoscope and surgeon's instrument. そうだな。Sorry. Appropriate size of craniotomy is about 2.5 and 2.5 by 3 centimeter. Craniotomy smaller than 2 centimeter is danger for endoscopic tumor removal, I think, because an interference between endoscope and instruments becomes strong. The most commonly performed technique for anterior skull base lesion is supraorbital keyhole approach with eyebrow skin incision. This is skin incision scar after 1 week and 1 year after surgery. Few cosmetic problems arise. Very beautiful scar. However, if you perform post-operative radiation therapy, hairline skin incision should be chosen instead of eyebrow incision, I guess, because one of my patients' eyebrow incision scar became strongly red after radiation therapy. So there are 2 types of skin incision for supraorbital craniotomy. One is eyebrow and lateral eyebrow, and another is short hairline skin incision. The patient who need postoperative radiotherapy or the patient who need lateral supraorbital keyhole approach, I often choose hairline incision because in lateral supraorbital craniotomy, incision line extend toward the out of eyebrow. So I perform the short or hairline skin incision. Eyebrow incision is made along the eyebrow in the superior edge. The supraorbital nerve is preserved medially, so medial limitation of this approach is supraorbital notch around here. Eyebrow incision. So after skin incision, curved periosteal flap is made and deflected. Next, 1 burr hole is opened on McCarthy point, and 3 by 2.5 centimeter craniotomy is done. The size of craniotomy is modified for each patient. So sometimes 2.5 by 2.5, and some patient need 3.5 by 3 centimeter craniotomy. Should be modified. The inner plate of the frontal bone and bony ridge of the orbital roof should be drilled to keep operative field widely and reduce brain retraction. After linear cutting the dura mater along the skull base, endoscope is inserted. Endoscopic subfrontal or Trans-Sylvian approach is performed. So brain retractor is not necessary during the surgery because at first I aspirate the CSF first. After operation, bone flap is fixed with titanium plates, and the bony gap is filled with calcium phosphate paste, and close the skin by layers. This is the general procedure in supraorbital keyhole approach and close the wound. This is final view. There are variations of skin incision and craniotomy. Basic supraorbital keyhole is particularly adequate to subfrontal approach for anterior skull base lesion, limited anterior skull base lesion, like olfactory groove meningioma, like this. The size of tumor is not so important problem. The surgical indication is almost same as general open craniotomy. lateral supraorbital or mini-pterional craniotomy is used for the lesion spreading laterally. For example, crinoidal meningioma, which extend both anterior and middle cranial fossa. Lateral approach is procedure for orbital lesion or medial anteromedial lesion of middle cranial fossa. Periauricular or supraauricular incision are used for anterior petrosal approach, subtemporal approach, or transcortical approach. In this case, this is a atypical tentorial meningioma. I performed the anterior petrosal approach by a small craniotomy. So around the keyhole is around here. So I will show you the representative cases of keyhole surgery. First case is right crinoidal meningioma, which involves the internal carotid artery halfway. I made a lateral supraorbital keyhole craniotomy and started endoscopic procedure. Right internal carotid artery was surrounded by the tumor, so I pulled out the tumor from under the artery. We can observe the space under the internal carotid artery and the origin of posterior communicating artery. Here is oculomotor nerve. Actually, endoscopic viewing angle is very wide, so residual tumors behind each structures are easily found. Here is Sylvian vein is running, which was also peeled off from the tumor. And the dural tail of the middle cranial fossa cauterized and shaved. Simpson grade 2 removal, including dural tail, was achieved. Dural tail extended chip of temporal base, but total removal was achieved. Next case, he is a young male. Unfortunately, pathological diagnosis was IDH wild glioblastoma. He was 25 years old. The tumor invades into the bottom of olfactory groove. It's difficult to observe from right side, left side, lateral side, you know. For such case, I start surgery using 0-degree endoscope to create space by removal of the tumor and aspirate CSF, and then switch to an oblique viewing endoscope. Although that is anterior skull base region, lateral supraorbital keyhole approach was performed because his frontal sinus was very large. By subfrontal approach, the tumor was exposed. Here is a tumor. The rectal gyrus entirely became tumor. So gyrectomy of the tumor, gyrectomy of rectal gyrus was performed. Now I scraped out the tumor invading the olfactory groove. Here is anterior edge of the tumor. Gyrectomy was performed. Relatively, tumor edge was relatively clear. After resection of the tumor, 5-ALA endoscope was used for confirmation. And now the endoscope was switched to 45 degrees. So we can observe the residual tumor inside of the olfactory groove. So remnant tumor was scraped out again using strongly curved instrument. So this suction tube is strongly curved, about 80 degrees, very, very strong curved. After this, post-operatively, tumor resection and the patient's condition were good. Adjuvant therapy for chemoradiotherapy was started early in the day. However, his incision scar became red. So if I have a chance again, I choose hairline skin incision. This is the case of posterior cranial fossa lesion, tentorial meningioma compressing the cerebellar peduncle. In this case, I used 30 degrees endoscope along the tentorium and look down the tumor. In the supine lateral position, patient's head was rotated to the left and 3 centimeter craniotomy nearby the transverse sigmoid junction was made. Separate the tumor about 3 centimeter craniotomy. We can observe the tentorium superiorly. Separate the tumor from the dorsal surface of the brain stem, and all of small perforators and nerves were peeled away and preserved. This is branch of SCA, and here is inferior end of pons. This is look-down view. Surgical manipulation under 30 degrees view is not so different from that under the 0 degree view. Unblock removal of the tumor was achieved. After confirmation of hemostasis, operation was finished. The tumor was totally resected. This is final case of keyhole surgery. Vestibular schwannoma with a diameter of 4.5 centimeter. Despite the tumor size, hearing ability was kept. She was a young female, about 40 years old. So I have to preserve her auditory function. However, this patient had high jugular valve. So opening of the posterior wall of internal auditory meatus would be restricted. In supine lateral position, 3 centimeter craniotomy was made. I started surgery using 0 degree endoscope, and then switched to 30 degrees endoscope for internal auditory meatus. Arachnoid membrane and here is lower cranial nerves. Lower cranial nerves were peeled away from the tumor. After developing of the tumor, root entry zone of the auditory nerve were detected, and continuous facial monitoring was started. In this case, internal auditory artery was also involved by the tumor, so peeled away and preserved. Here is high jugular valve. I'm drilling the posterior wall of internal auditory meatus. But width of bone window was narrow compared to usual surgery because of high jugular valve. But by use of 30 degree endoscope, visibility was pretty good. Here is residual tumor. Residual tumor was removed in fundus in internal auditory artery. We can observe the auditory nerve and the branch of internal auditory artery. This is final view. Post-operative course was good. Of course, no facial palsy, and the hearing ability slightly improved. This is post-operative scar. Finally, I introduce our new trial for elderly patient. In a rapidly aging society, treatment of elderly patient with intracranial tumor is important issue. According to previous studies, mortality and morbidity of elderly patients undergoing meningioma resection were significantly worse than young patients. It's reported that the relative risk is 3 times. In addition, elderly patient easy to become bedridden by muscle atrophy, delirium, infection, and so on. So, therefore, we try to less invasive debulking surgery for an oldest old patient with benign tumor. Surgical strategy is a small skin incision and small craniotomy, enlarged burr hole. No aspiration of CSF, debulking only inside the tumor, but stop the blood supply enough. This is our concept of debulking surgery. Example case. He was 85 years old male. Ataxia in his upper extremity became gradually deteriorated. In this case, I made 2 cm craniotomy. After cutting the dura mater, devascularization was performed enough. Maybe these are main feeders for the tumor, I think. After devascularization, the debulking procedure was performed and finished the surgery. Postoperatively, inside of the tumor was hollowed out, and the residual tumor had gradually shrunk. In such a surgical strategy, patient's recovery is really fast. This is launched on postoperative day 1. Sorry. Can you believe he is 85 years old patient and who received open craniotomy surgery for the huge posterior cranial fossa meningioma. This is day 1. So I summarize the advantage, disadvantage, and problems of endoscopic keyhole surgery. The largest advantage is, of course, visibility in deep portion. It eliminates blind spots and contributes to reduce retraction injury. Excessive exposure of brains can be avoided by small craniotomy. Fewer limitations of surgical position of patient and surgeons, and underwater surgery are unique and useful characteristics of endoscope. On the other hand, interference between an endoscope and surgical instruments become a problem. So in our university, assistant surgeon controls the endoscope as a scopist to avoid interference. As another disadvantage, the objective lens frequently get soiled when we use drill or ultrasonic aspirator, and we have to wash the lens. However, in general, advantages of using endoscope far outweigh the disadvantage, I guess. summary and conclusion. Endoscopic keyhole surgery is very useful, smart, and patient's recovery is really fast postoperatively. So I hope you will give it a try after enough training of general microscopic and endoscopic surgery. Thank you very much, everyone.
Ishida-sensei, thank you so very much for this wonderful presentation. It covered almost every single topic from the basis to the advancements. And please let me try to say it in Japanese if I can. Don't mind my accent. Kishida-sensei, このセッションの技巧を突めさせていただきました。いつもご利用いただき、ありがとうございます。
Thank you. Thank you very much, Professor. Well, very
it
good
truly
in Japanese.
is.
Yeah.
Thank you. It's
Actually, Aaron, we cannot understand what you said. Please say in English, please.
Excellent Japanese. Thank you. Thank you.
What I tried to say and missed my accent is a true honor and a privilege to chair the session. At any point in life, all of us can learn, and you presented us the way how it can start, the way how you can progress, and the way how you can grow. This is a session for young neurosurgeons, and I want to take advantage of sharing not only part of my experience, but what I've learned throughout the years. And I'm so very happy that I already see raised hands. So before moving on with any comments from my end, I would like the opportunity to go on to first to Ben, and then to my dear friend Chen with the question that they have. So Ben, please go first.
Professor Kishida, thank you so much. And although I cannot speak in a Japanese accent, but it's my pleasure that you come here to share about your experience in minimally invasive surgery. So with the advance of the endoscope, so I personally myself also do endoscopic surgery, but not as advanced as you do. So I'm so glad that you open an eyesight for me and for the concerning the limit of the endoscope. And thank you so much for this. So my question is that during your surgery for the supraorbital approach, so how would you manage those with a large frontal sinus? That how would you repair those with a large frontal sinus if you need to open it during the endoscopic surgery? And my second question is about the, I saw you have drills for the endoscopic surgery. So it's quite advanced and also technically difficult for me to imagine. So may I ask for the tips for the drilling of bones, for example, anterior gynoid or internal acoustic meatus? How would you, any tips for the drilling, and do you need to use different degree of angle drill with irrigation to perform this maneuver? Thank you so much, Professor Kishida.
Thank you very much, Dr. Ben. For first question, for the patient with large frontal sinus, right?
Yes.
Yeah. I show you the illustrative case. If frontal sinus is very large, I choose a lateral supraorbital or sometimes mini-terional approach, more lateral approach. Generally, I choose the lateral supraorbital. But in that case, incision scale extended outside of the eyebrow. So I often choose a small hairline skin incision like this. And we have to prepare the periosteal flap for that case. For if we open the frontal sinus, we have to close by periosteal flap. So, and the another disadvantage of small craniotomy or keyhole surgery is less than repair tissue is not so many. Sorry, my English is not so good. General craniotomy, we can use the muscle or part of our fascia, but in keyhole surgery, we have only periosteal flap. So keep periosteal flap clear.
Because I see your incision that if you extend slightly lateral, and you might able to use a bit of the temporalis to rotate forward. I saw this maneuver performed by some surgeons.
Extend laterally is not correct. Extend inferiorly, because about 15 or to 25 centimeter from eyelid, facial nerve is running. So outside, extend inferiorly and diffract the skin, another skin flap inferiorly.
Yes.
Inferior and superiorly.
Yes. Another is about the drilling. How would you perform the drilling?
Sorry.
Another question is about the drilling technique that you use.
Drilling
Drilling of bone. Drilling.
The drilling technique during
drilling
yes,
technique
the drilling dips.
Yeah.
During the procedure.
During for example, internal auditory meatus. Technique, just a training.
Do you need to use those angle drill?
And now, basically straight.
Straight.
For correct manipulation. So, I don't know. About for the internal auditory meatus, posterior wall, I use a 2 millimeter diameter coarse diamond drill, or sonopet, ultrasonic drill instrument that's carved vertically. So I use sonopet or a straight 2 millimeter coarse diamond.
I see.
Those are 30-degree endoscope. Look up view.
So do you have the small size of the sonopet?
No, same. Basically same instrument. So for the vestibular schwannoma case, for example, MVD or tumor inside the CP angle, 2.5 centimeter craniotomy is enough. But for vestibular schwannoma, we have to extend posteriorly about 1 centimeter, 2.5 and 3 centimeter for the drilling of internal auditory meatus by straight drill.
Thank you so much again, Professor.
Thank you very much.
Today. So we got past the time to second orator.
Chen, I see your hand is raised. Do you have a question for Dr. Kishida?
Yes, thank you so much, Professor Kishida. Every time I'm also very thankful for ACNS and Young Neurosurgeon webinar. Every time I learned a lot. I'm very enjoying your amazing operation and very beautiful pictures. It looks that endoscopic surgery for tumor can resolve almost everywhere, can reach everywhere, almost can replace open cranial. So in your opinion, what kind of location of tumor is contracted or cannot use endoscope?
In my opinion, there's no place.
No place everywhere.
Yeah,
And
everywhere. I think.
Yeah, very deep.
Not. I think indication of endoscopic keyhole surgery is not size or location or tumor pathology, but I think cerebrovascular disease is not good for endoscopic keyhole surgery because, for example, aneurysm creep is large and interference with endoscope is very strong. So, tumor surgery is removal surgery from the surgical field, but cerebrovascular disease is often insert surgery. So, I think basically for the tumor, no limitation of location or size of the tumor, I think.
Okay, and do you publish your operations? Do you compare open cranial and endoscope, such as the advantages such as save time and less bleeding, and the patient can recover very quickly? And I do believe you can share your experience with global patient neurosurgeon.
Thank you. I think.
Yeah.
I will consider. Yeah.
And regarding the disadvantage, I think maybe we can improve the instrument of endoscopy, such as the flexible, deep, and can make the short or the short and the length. Okay, and the drill angle can change the angle, and the transplant tube, and you can make you a very clean view in the operation field, and the section such like this. We can. Do you have any idea to improve the device of endoscope?
Very good question, I think. But in my operation, actually, using instrument is almost same as a microscopic surgery. So, for example, endonasal surgery is I use different, only specialized instrument for endoscopic surgery, but keyhole surgery basically same. For your question, well, generally it's useful for single shaft and rotatable, and straight shaft and curved in the tip, and the rotatable instrument is very useful for avoid the interference between endoscope. So, and we use washing instrument for endoscope by foot switch. So,
Thank you so much. I
Thank you.
Yeah, we have many work to improve the endoscope technique. Thank you so much.
Thank you very much.
Dr. Kasanov, did I see your hand raised or no?
Hi, konbanwa, Kishida Sensei. Thank you very much for excellent presentation. I am Dr. Hasanov from Uzbekistan.
Yeah.
I have recently arrived at Tashkent, and I trained as an endoscopic surgery fellow under Dr. Takeuchi at Nagoya University Hospital.
Oh.
So I had a chance to assist in his surgery. We did endoscopic supraorbital keyhole approach for decompression of optic nerve, because there was a huge large meningioma, cellular meningiomas. So my question is, I'm not going to ask a question. I'm going to ask your recommendation regarding instrumentation, because in Uzbekistan, unlike in Japan, we don't have an endoscopic holder like a pneumatic Mitaka or Olympus. So it's a little bit difficult to hold this endoscope to make it stable during a keyhole surgery. Sometimes we hold the endoscope, but during the manipulations, surgeon can move endoscope accidentally, and it might lead to injury for nearby structures, because a less experienced doctor, as we have a less experience in the manipulating instruments in a deep and narrow space, and we don't have a stable endoscope during surgery. In this case, what do you think? So it is a little bit easy to obtain a mechanic endoscopic holder.
In endonasal surgery, scopist complete freehand scopist is useful, but in this transcranial surgery, I think mechanical secure endoscope holder is necessary. Freehand holder by assistant is very dangerous. Sorry. So especially I think a floor standing type is more suitable. The simple arm type of holder is a little unstable. So that's not suitable for transcranial surgery, I think. Is it okay for your question?
Dr. Hassanov.
Because I tried to use endoscope and instruments during my assistance. So it was a little bit difficult for me when this is a stable endoscope in Nagoya. Now I am thinking it's difficult to start without endoscopic holder in Uzbekistan.
So at first you start the surgery, endoscope assisted microscopic surgery. After microscopic procedure, use endoscope for confirmation the behind of the structures. And at that time, you put on the edge of craniotomy, not free area, put on the edge of craniotomy and make endoscopes stable. This is first step, I think.
Okay,
Dr. Hassanov, I want to thank you for that wonderful question. It's not only about advanced countries like Japan, and this is the case of these webinars where we have friends and colleagues join us from all the world who practice neurosurgery under conditions and limitations just like that you mentioned. So one more time, I thank you very much for bringing that case. That was a wonderful question. I see that Dr. Azos from Cancer Children's Hospital in Cairo has her hands raised. So please, your question or any comments you might have.
Yeah, thank you. I just want to ask two quick questions. I think already Dr. Ben have asked a similar question for it. In drilling the internal auditory canal, do you rely mainly on the neuronavigation to know the limitation of the drilling, or do you have an anatomical landmark that stops you on and off, or is it the measurement that you do preoperative? The second question is, during your surgery, the endoscopic surgery, do you start with a microscopic surgery to introduce the endoscope, and then you start with the endoscope, or you start primarily endoscopic? Thank you.
Thank you very much. For first question, sometimes I use navigation, but anatomical landmark is not so necessary. Just start from the edge of internal auditory meatus and confirm the dura mater and drill to the superior side. Not so.
But aren't you afraid of the superior semicircular canals in this area?
Mainly use navigation system. Sorry. And the second, what was the
you
second
start
question?
with microscopic surgery, the microscope to introduce the endoscope, or you advance straight ahead with the endoscope from the beginning?
Well, endoscopic beginning. I think at first we have to experience the microscopic surgery enough, and after that, for the training of endoscopic surgery, transnasal surgery is adequate, I think, because we have to surgical depth is very long and very narrow space, and we have to manipulate the instrument adequately. So, so 段階的に言うとそうだな。First, microscopic surgery, and second, endonasal endoscopic surgery, and transtubular retractor surgery, and keyhole surgery, I think. Gradually developed, I think.
All right, thank you so much.
Kishida sensei, I do believe that Dr. Azaz wanted to ask, during your keyhole procedure, would you start from the beginning with endoscope, or you open your field with a microscope and then you move on to endoscope? Can you hear me?
Sorry?
Her question, I think, was in regard with your keyhole procedures.
Yeah.
As you prepare for the surgery, you start with a microscope and then you move to endoscope, or from the beginning you have a plan only with endoscope?
Sorry, only endoscope from beginning.
Only endoscope from beginning.
Yeah. Because basically I perform the same procedure of microscopic microsurgery. Microscope is not necessary.
Yes, I got your point. Thank you.
We have our dear beloved colleagues here from Ukraine, and then Dr. Pirzad from Afghanistan. But I would like to ask Dr. Wozniak here, joining us from Ukraine today, how does he see the challenges of the limitations for the young neurosurgeons to start to learn the endoscopy and then to grow and practice it, just like Dr. Hasamov from Uzbekistan mentioned that challenge?
Thank you very much, Dr. Professor Kishida. For great presentation, for very good analysis, very great review, which let us understand the difference between micro and endo. But you didn't mention what kind of endoscope you use, 2D or 3D? Which one? 2D or 3D micro endoscope?
2D.
2D. So that's the question.
4K 2D endoscope. Yeah.
Okay, so thank you very much. So because then you didn't mention the main disadvantage of this tool, because you have the 2D vision, and it especially for those who switch from micro to endo, it's a big disadvantages for me was because to switch from 3D to 2D, I think the main reason of learning curve to start do everything endoscopically. Of course, with time, with experience, this disadvantage gets less and less and less, and finally minimizes. My question is, do you think that all the cranial procedures could be performed with endo? So I will extend the question by Dr. Chen and Dr. from Egypt. So generally, how do you think? Do you can perform everything with endo, or just you must select the patients for cranial surgery? What is your option?
I said all, but sorry. Superficial lesion or the surgery, we need a large craniotomy. For example, low-grade glioma located in surface. Sure, I open large craniotomy and directomy. But in deep portion or skull-base region, basically, all of microscopic surgery can be changed to endoscopic surgery, I think, for the deep region.
Yes, actually, what I wanted to ask you. Thank you. And I will move on with my questions and my comments. When you showed us anterior fossa cases, great, very good cases. Thank you very much. My comment is that the opening of frontal sinus is not such a big problem. So if you need it, you can open then just close the mucosa. And in my practice, I have no. I also try to avoid the opening, but once you open it, or you need to open, especially when you have a very big sinus to laterally, almost to the goma, it's not a big problem. And even CSF after surgery stopped by itself without any special surgeries. But my question is a little bit another. Have you ever considered the endoscopic interhemispheric approach for anterior skull-based tumors, especially on olfactory groove part? Because in my practice, I do it micro. I go interhemispherically through the very small craniotomy, but with microscope, not with the endoscope. But have you ever considered to do it with the endo?
Interhemispheric approach to the anterior skull base, for example, olfactory. That's interesting, but I have never experienced. In my opinion, the basic surgical strategy for the tumor, I think I should reach directly to the origin of the tumor. Directly. So not for from interhemispheric space. We have to approach the tumor from the top of the tumor. But in my opinion, we have to reach to the tumor from bottom, original site of the tumor, I think. So I choose the skull base approach.
Okay, thank you very much. And the last question, do you perform the embolization of meningiomas before surgery?
Sometimes.
I think it's sometimes.
Sometimes for the large tentorial meningioma, we sometimes embolize the tentorial artery or something. Thank you very much.
Thank you very much. Thank you for the great lecture. Thank you.
Welcome. Thank you very much.
Dr. Wozniak, thank you so very much for joining with your questions. Always a pleasure. Professor Perzat, please.
Yes. Hello. Thank you. Thank you very much. This Dr. Perzat from Afghanistan. Thank you very much, Professor Kishida, for your excellent and nice presentation and for sharing your experience and recommendation for young neurosurgeon. And for your information, I like to say that in Afghanistan, we still use transcranial approach for brain tumors, and unfortunately, we haven't the possibility of endoscopic and microscopic. We have a old microscope, but we do it oftenly use we use loops for during the operation. And I'd like to know that do you use neuronavigation during this operation, or use, sometimes I heard about the CT scan or MRI to remove the tumor completely or not? Thank you. Arigato.
Arigato. Thank you very much.
Kishida Sensei.
Yeah,
I think Dr. Pirzad's questions was if you use intraoperative imaging to explore
CT or
remnant.
MRI. Yeah.
Yes. Or do you
I don't
relay
use.
on? No.
No.
And
only
do you
one,
relay?
Yeah. Only one
yes,
case. Only one case. The large thalamic glioma case. I used the intraoperative MRI. I transfer the patient to the another hospital and perform the surgery for intraoperative MRI because thalamic glioma, the location is there are no landmark in the operative field. But in many skull-based surgery, we can observe the major landmarks or anatomical structures. So basically, I don't use the intraoperative radiological examination.
Arigato. Arigato gozaimasu.
Welcome. Thank you very much.
I see Dr. Chen, your hand is raised. One more time, please. Is that any question?
Yes, I forgot a very interesting question, but the question is similar with Professor Fawad. Finally, we are focusing one point as the bone flap, the relation to the tumor lesion field. So how do you make a very precious bone flap in the before surgery and in the surgery? When you make a skin incision, maybe you lost the skin mark. So how can you make the bone flap very precious? Because your bone flap very, very small. Do you have experience in your surgery? You have to expand the bone flap because you need a more vision, the size. Yeah. So maybe I'm thinking maybe if we have a kind of a computer design software, maybe we can get a very more precious design, such like a CAD design. Yeah.
Thank you very much. Good question. I have several cases. I open and expand craniotomy during surgery, but about 1 centimeter. Because, for example, one case was anterior cranial fossa tumor, but very large and height, very high. And first craniotomy, I couldn't reach to the top of the tumor, so I drill out, remove the orbital limb. Like an orbital approach. Only remove the orbital limb. Well, sometimes I enlarge the craniotomy, but not so many. And for second question, yes, I make 3D and planning for the small craniotomy keyhole surgery. For the cranial keyhole surgery, preoperative planning is very, very important. Where should we open, and can we reach to the around the tumor? We have to confirm preoperatively by the 3D planning. Yeah, that's a very important point. Yeah, good question. So the location and the size of the craniotomy is modified and different for each patient based on the preoperative planning.
So before the operation day and in the operation, you make the landmark on the bone flap, right? How to measure the location?
Yeah, measure and by navigation system.
Even navigation.
Before the skin incision and the marking, I use the navigation system and mark by pen and start the operation.
Okay, so you do twice before operation. You measured, and in the operation you use the navigation. But I think a navigation also has a problem. It's a floating the location in the operation.
Yes. That's a big problem of the navigation system. So mainly I use the operative planning or to decide the location of craniotomy or skin incision, not the during surgery. After reaching the tumor, navigation system is not so important. That's very important for the deciding the craniotomy and the skin incision, I think.
Okay.
And drill the drilling area of the skull base bone.
ありがとうございます。
Welcome. Sorry, my English is not so good. Sorry.
We can understand you. We can understand.
Your English is very okay.
I have to study.
Yes.
Your English is wonderful.
ありがとうございます。
ありがとうございました。
I cannot thank you enough for bringing the high quality lecture here with us. You see, there are so many questions. If I am allowed, I'll share a couple of experiences now, and then I'll move on to the next speaker. I'll share some personal notes that I've gathered from conversations that I've had with Professor Charles Dio. Charles has advanced the endoscopy to higher levels. But for us who are at the starting point, I would like to start and take note from Dr. Kishida's practice. We don't need narrow navigation during surgery. In general, narrow navigation is required for us to landmark before the opening, the starting point. It is always important to know the anatomy. Yes, there is going to be floating during the surgery as we are speaking about tumors, but any shifting during the surgery is based on the knowledge of the anatomy. So you can advance starting with a microscope, as Dr. Azaz wanted us to show that we start with a microscope and then we can advance with endoscope. It doesn't have to be always endoscopy from the start. For those who want to learn endoscopy, it is always recommended that you know the anatomy. You start with microscope and then you learn your skills with endoscope, usually and in general with close to the skin lesions. And one very important point that Dr. Wozniak made is during his question is that limitations to endoscopy are knowledge to bypass surgery. What does that mean? And this I have from Professor Spetzler, who I don't think has ever left any tumor behind with his skills. So what that means? You cannot perform or advance in your endoscopy techniques if you do not know your limitations. You have to be prepared to stop your endoscopy and then move to open to your microscope and know how to conduct bypass surgery in case that is required, which is to say that is the limitations. Dr. Kishida mentioned that use of clipping with endoscopy is limited to the size of the clips that we should know. And in regard with Dr. Hasanov in Uzbekistan, I would highly suggest what Charles Dio does. He, as a traveling professor in countries with limited resources, uses physical assistance. So he does not have an arm to perform his procedures. In these cases, he is there to help colleagues throughout the world with limited resources to teach the techniques of endoscopy. And he starts with tumors that are close to the surface. It doesn't matter if that's a meningioma or a glioma. the only recommendation I would give for those who would want to start practicing endoscopy in a glioma is you use the largest diameter of a glioma to consider as your entry point. If that's an ellipsoid, you start from the largest diameter of that figure in glioma to start your figure point, because there is less shifting as you progress with the removal of the tumor. So these are only a few points that I wanted to add, but in no way I can spoil the highly interesting presentation from Dr. Kishida. And I'm so very happy that I see Dr. Islam raised hand. Dr. Islam is joining us from Dhaka. Dr. Islam, do you want to join us with your question? Thanks.
Thank you, Professor Kishida Sensei, for your brilliant presentation. Personally, I like the presentation very much because I am interested in endoscopic skull-based surgery and exoscope surgery. Being a young neurosurgeon, what tips you should suggest us from where we can start? Because in our country there is no Mitaka or Olympus. So you suggested you first do microscopic surgery, then put your endoscope. And will you give us any more suggestion? And one more question, that you're doing all kinds of keyhole surgeries. Do you feel any difficulty to introduce the endoscope initially due to difficulty in brain retraction? And do you feel any difficulty to make free the vessels that are encased in some of the tumors? Which is better, microscopic dissection of vessels or endoscopic dissection of this kind of tumor where there is encasement of vessels? Thank you.
Thank you. Sorry, your question is, the first question is the training of the starting endoscopic surgery.
Will you give us some more tips from where young neurosurgeons like us can start to do this type of surgeries?
This type, I think the endoscopic keyhole surgery is the final stage of endoscopic surgery. I recommend at first endoscope assisted microscopic surgery. That means the microscopic surgery using endoscope for the assist. This is the first step. And the second step is endoscopic hematoma evacuation or biopsy endoscopic surgery is second stage, and then endonasal surgery, and finally you started to keyhole surgery after microscopic keyhole surgery.
Okay. Yeah. Thank you. And my second question was, do you feel any difficulties to dissect the vessels that is encased while doing endoscopic surgery?
Basically, in keyhole surgery, I said previously, basic manipulation is the same as open craniotomy surgery, microscopic surgery. I want to perform the microscopic microsurgical technique under the endoscopic view. So surgical, for example, B-cell dissection or peel out the nerve from the tumor. So manipulation is basically same microscopic surgery and my keyhole endoscopic surgery. So maybe your image of endoscopic surgery is endonasal surgery for the only curating or full surgery. That is dangerous. That's not good for the intracranial tumor. We have to perform the endoscopic microsurgical technique. So just the difference of optical device, procedure is the same, microscopic surgery and endoscopic surgery for me. Okay.
Okay. Thank you. Arigatou gozaimasu. I'm learning some Japanese. Thank you.
Thank you very much. Welcome.
Can I,
Kishida Sensei.
can I ask Kishida Sensei?
Please.
お手柔らかにお願いします。
Kishida Sensei, どうもありがとうございました。Maybe
ありがとうございました。
can understand a little Japanese. Just I want to ask, because it's the time of the paradigm of the neurosurgical surgery, I think, because the maximum invasive to the minimal invasive. So that means it's endoscopic, the pure endoscopic surgery is very, very important for younger generation. So do you recommend, do we need some very basic microscopic training, or maybe you use exoscope plus endoscope? So I think, of course, you trained at the Fukushima University. There's so many skull-based, very difficult case. So what is the recommendation for future the young doctors? Because let's say invasive for the patient and also for doctors. I think what is the recommendation? And also for you, I think no more limitation for endoscopic surgery at your practice. How do you think?
あと、first question. そうですね。Well, but yes, this is paradigm shift, I think so. But the endoscopic keyhole surgery and other surgery is based on the classical microscopic surgery, microscopic technique, microscopic manipulation. So we have to start surgery like this after basic microscopic surgery. For exoscopic surgery is, so you know, exoscope is good instrument, but the quality as optical device is not so good compared to microscopic surgery. Present microscope is really good and high quality, beautiful view and bright, and we can use 5LA or ICG or something. And exoscope is, quality of exoscope is not so high even now. So now we have to start basic microscopic surgery, and after enough training, do the endoscopic surgery. でよろしいでしょうか。And exoscope is assist or so it's useful for us. We are trained and experienced for the heads-up surgery and visual display surgery, so we can use the exoscope easily. But for the young surgeon, have to wait quality of exoscope become more better, I think.
Thank you very much for the excellent presentation. Congratulations. Thank you. Thanks so much.
Dr. Kishida, it's a very intriguing lecture. Thank you very much. If I may add one final note from the question that Professor Kato had, I want to bring some advice from late Professor Axel Pernetsky, who started maybe one of the fathers of endoscopy. Axel Pernetsky himself started endoscopy as endoscopy-assisted microsurgery. So he would perform debulking, he would perform a tumor removal, he would perform a skull-based surgery, and then he will use an endoscope to assist him see maybe the blind spots. At that time, it was not so advanced as to have 30 degrees or broad-angle endoscopes, but that's how it starts. That's how how we developed our skills. For those who have the settings, it's best to start that way and then grow out of it. Yes, of course, you can have the help of ENT surgeons. They can start the procedure from you, and then you move on with transphenadal and the nasal approaches. Okay, I think it's about time to move on with our next speaker. So Kishida Sensei, arigatou gozaimasu for being with us here tonight. A wonderful joy. And thank you very much to all and everyone who had questions. It's an intriguing topic. No one can stop it. It will go on for hours. Sachin, would you please take it on from here, or maybe Lou, and help us present our next speaker, who is going to be Dr. 𝒂𝒑𝒊𝒂, currently a fellow at Bantana and a neurosurgeon from Malaysia. Thank you, Sachin.
Thank you very much, Professor, and everyone. Thank you.
Thank you so much. Maybe a surgeon is not feeling well, and I may introduce our next speaker, the YNS speaker, Dr. 𝒂𝒑𝒊𝒂. 𝒂𝒑𝒊𝒂 is the neurosurgeon in the neurosurgery department of Penang General Hospital in Penang, Malaysia. So he also have experience in working in the Fujita Health University, and also in the Benten Hospital, Nagoya in Japan. And so without further delay, so may I introduce our the topic of today, YNS speakers webinar, which is the endoscopic evacuation of subdural hematomas. May I introduce Dr. 𝒂𝒑𝒊𝒂 to come to us?
Hi, good evening. Can you hear me?
Yes.
Yes. It's a great honor to be able to present in front of all the great professors. Thank you so much, Professor Yokokato, for giving me this opportunity to share some knowledge with the viewers here. Okay, let me share my screen. Okay, can it be seen?
Still waiting it to be shared. Yes, we can see it now.
All right, great. Okay, my name is 𝒂𝒑𝒊𝒂. I've been a neurosurgeon now for 2 years, graduated in 2021 in Malaysia. So today, the topic I would like to share with everyone, especially the young neurosurgeons, is on endoscopic evacuation of acute and subacute subdural hematomas. I will not be talking on chronic subdural hematomas. That will be a totally different topic altogether. Okay. So the main purpose of me presenting this is that when I came to Fujita Health University, Bantana Hospital, Nagoya, I've learned about this technique, and I think it is very useful. And I hope that after this presentation of mine, other neurosurgeons would be able to pick up on how it's done, which patients to choose, and maybe the slight nuances and how to start doing this surgery in their own practices. Okay. So I have nothing to declare. So I'd like to thank all the neurosurgeons in Fujita Health University, Bantana Hospital, for allowing me to use their cases and share their videos for this presentation. So the content of my topic today will be acute and subacute subdural hematomas. Why endoscopic evacuation instead of doing the traditional craniotomy or craniectomy? The criteria for suitable patients, not every patient can go through this procedure safely. The equipments needed, the risk specific to this technique, 2 case studies, and a little bit of Fujita's experience on this. Okay, let me begin by asking everyone here, what do you think about these 3 people? They look very old, right? The person on the left there is an Indian gentleman, seems to be the oldest person in the world at about 130 years old. If these people come to you with an acute subdural hematoma of 1 centimeter, but with a GCS of E4, V5, M6 with headache and some giddiness. If they are 70 years old, 80 years old, 90 years old, some even 100 years old now, with our aging population in the whole world, and especially also in Japan, would we consider doing a craniotomy or craniectomy as proposed by the Brain Trauma Foundation? Or some of us would actually just say, I think you're too ill, you're too old, I don't think your mom, I don't think your dad would be able to go through the surgery because there are too many comorbidities, the risk is too high. And from studies shown, patients who are above 70 years old, even after doing a craniotomy and evacuation of clot, the morbidity is so high, the chances of being independent after the surgery is low. No, we won't offer surgery. Or would we offer craniotomy or craniectomy? Or maybe another option in which some people perform nowadays is to maybe just wait for 2 to 3 weeks, wait for the acute subdural hematoma to turn chronic, and then just do a burr and drainage after that. So in addition to all these options, now with the advent and availability of endoscopes and equipment, I think we can add on to this list, which is endoscopic evacuation of the acute subdural hematoma. So just a bit of background on acute subdural hematomas. The 6-month mortality rate has been reported at as high as 58%, poor outcome at 80%. That is even with craniotomy and evacuation done. The guidelines by Brain Trauma Foundation was nearly 2 decades ago already. They recommend if it's more than 1 centimeter, midline shift, more than 5 millimeters, you go in, you take it out. If there's deteriorating conscious level, or if your ICP monitor shows that it is raised more than 20, go in and take it out. How to go in and take it out? Craniotomy, craniectomy, a large surgery to encompass the entire cranium and the whole clot so that we can reach the entire surface. But is this relevant? Is this recommendation relevant in the elderly population with such high rate of poor outcomes for craniotomies? So maybe if we try minimally invasive surgery in these elderly patients, the outcomes would be much better. Okay. So this is the original paper by Brain Trauma Foundation, which recommended the craniotomy and craniectomies. There is no mention of age at all. And if you read through the entire paper, there are a lot of papers here and there, but in the end, there's no conclusion. You just know that the older you are, the worse the outcome. Okay. And if it's greater than 1 cm, regardless of the patient's GCS, we should do a craniotomy and craniectomy. That's what was recommended. So this is a recent article in 2021 by Spetzer et al., in which he gathered 13 studies that did endoscopic evacuation of acute and subacute subdural hematomas. In total, there were 13 studies, 122 patients. Okay, the age range, you'll be surprised, is from 65 years old to 101 years old. The mean age is 78 to 87 years old. Okay, the ones in red is the mortality by craniotomy. So in these studies, you can see that the mortality can be as low as 0 to 40%. So it's either lower or actually comparable to open craniotomy surgeries. The poor outcome is actually good, 3.6 to 73% versus 80% by open craniotomy. Of course, this is not apple to apple, and this is just case series. They're not comparing properly, and they are all retrospective studies. Okay, so we have to take with a pinch of salt. Okay, so why endoscopic evacuation? I think it's obvious. I think even from the first lecture just now, it is very obvious that in elderly population, there's a great advantage in using endoscopic minimally invasive surgery. You don't need a large craniotomy or craniectomy, and you only need a small craniotomy, most of the time 2 to 3 centimeters only. The rate of evacuation is actually good. It's 80 to 90% from all the papers. There's only like 10 to 20% left behind. That is actually acceptable because the main thing you want to do is decompress and say reduce the mass effect from the subdural hematoma initially. Less operative cost and time. You see, patients actually get to eat on post-op day 1. So they stay shorter times in the hospital, cost less, and since the skin incision is smaller, opening, dissection, closing will be much faster. And the most beautiful part is these small craniotomies can be done under local anesthesia. When you can do a surgery under local anesthesia in patients with many comorbidities, you actually save them a lot of dangerous parts of general anesthesia. For example, pneumonias, strokes, myocardial infarctions, renal failure, and now newly recognized problem of post-operative cognitive decline after general anesthesia. And of course, with small incision, the blood loss will be minimal. Smaller wound would also mean lower risk of a wound breakdown. So let's dive into the criteria for suitable patients. I think the patient selection is very important when we want to embark on this type of surgery. So in most papers, they recommend age more than 60, some more than 70. But I would have to highlight in this aspect is age is actually just an arbitrary figure. The main point here is that in older people, there is cerebral atrophy. And when there's cerebral atrophy, there will be space for us to put in the endoscope and maneuver. When in young patients, the cerebral edema will be more, there will be less space to put in the scope, and the brain would herniate out. So in these kind of cases, it's not so suitable. However, having said that, while preparing for this little session, I came across papers in which they actually used endoscopic evacuation for younger patients. And in these younger patients, usually they will have other diseases. For example, some of them have schizophrenia, and the brain is also atrophied, and it looks like a 70-year-old's brain. And in this case, they successfully actually completed the endoscopic clot evacuation. They don't need to be elderly. It's mainly the cerebral atrophy which is needed. So of course, your patient has to be symptomatic. In terms of what is the size and thickness of the subdural hematoma, all the studies earlier which I mentioned did not comment on the thickness of the subdural hematoma which they have evacuated. The patient must not have high risk of bleeding. They must not have thrombocytopenia, DIVC, congenital coagulopathy. Use of antiplatelet and anticoagulant is actually subjective. In fact, all the papers that I've gone through actually do say that it's an advantage, because in patients who are elderly, the very high chances that they are on some anticoagulant or some antiplatelet. And if surgery is needed anyway for them, a small craniotomy and a small skin incision is going to incur much less blood loss and much less bleeding as compared to a large craniotomy. So it is actually an advantage and not a disadvantage doing endoscopic surgery. Of course, some people will say, oh, if endoscopic surgery, you may have trouble securing the bleeder and all that. That is maybe through experience and the equipment you have. Okay, the next important part is the patient should not have other lesions in the brain. For example, an ICB, a contusion, or very bad cerebral edema. In this kind of patients, the brain may herniate and may block the view, and actually a small craniotomy may actually cause further problems for the patient rather than helping them. Okay, the last criteria is also subjective. Some of the studies actually chose patients with GCS less than 9. And even with unreactive pupils, both sides dilated, they also did it. But I can see that in this kind of patients, if the GCS is less than 9, if 8 and below, then you will not have the advantage of doing it under local anesthesia. You will have to do it under general anesthesia, as these patients won't be able to protect their airway, and you will need to intubate them. So this again is a subjective thing. Okay, the steps. It's actually just the same as any other craniotomy, mini craniotomy. So if you perform it under local anesthesia, you give local anesthesia on the spot, on the skin incision, you give sedation and analgesia. You raise up the shoulder on ipsilateral side, you make a skin incision 5 to 6 centimeters, then you perform a craniotomy 2 to 3 centimeters. The position of the craniotomy is important. The craniotomy is best to be centered on the thickest point of the hematoma or where there is an acute clot. This is so that we can find the bleeding point and able to reach the rest of the clot. Okay. You don't really need an assistant. One person is enough. You hold the rigid endoscope in one hand and you hold the sucker in the other hand. So what are the equipments needed? You need a rigid endoscope. Of course, if you have a 30-degree lens, that would help a lot. Some have used the flexible scope, but mind you, the flexible scope has poorer optics. And using the flexible scope, you most likely will need an assistant at the same time. And another important equipment you need is the malleable suction cannula. This is a must. The cannula will act as the main instrument you're going to use to evacuate the clots. And at the same time, it's used to depress the brain and retract the brain slightly. Bipolar, if you have angled one, of course, it's better. And our usual oxidized cellulose to put on areas of where there's bleeding. So these are intraoperative pictures. You can see the malleable cannula. You can bend it to whichever angle you want to help you. You can bend it up to the left, to the right, okay, so that you can suck into it. And then your other hand is holding the scope. Okay, these pictures just to help illustrate actually what happens during the surgery. So in this picture here, you can see the malleable cannula will be, one end of it will be pressing on the brain and the other end will be helping to suck the hematoma. And this will be your scope. So from this picture, you can see that one risk is damage to the brain. When we are looking at the monitor and evacuating the clot, we have to be wary at this point here. At the point of entry, we can actually damage the brain. Another thing is these patients, since they are done under local anesthesia, they can actually move. So in this kind of instances, it is important that maybe you explain to the patient and also your assistant to hold the head, so that there's not too much of movement during the surgery. Okay, so this is an example of the malleable cannula. Okay, this is a picture to illustrate the importance of where the craniotomy should be placed. If you place it at the eccentric region in which it is too far from the center of the clot, you will not be able to reach the other portion of the clot. It is best you put it at the epicenter where it's thickest, so that you can reach the ends of the clot. Some of them have actually done cadaveric studies, and they find that an ideal position for the craniotomy in this kind of cases is where the superior temporal line meets the coronal suture. And they said that from this place, for most skull shapes, you will be able to reach the ends, most ends of the convexity. So the risk for this, I've mentioned, the damaging the cortical surface. It is important that we take note about this. Some people actually put a layer of protection on the entry point so that when they enter and they exit, you don't damage the brain surface. The other thing is to be careful about tearing the bridging veins. If we retract the brain too much or press the brain down too much, you might end up tearing the bridging veins. The others, inadequate hematoma, evacuation, rebleeding seizures, are general things which you can even experience with a craniotomy. So let's go on with our case study. The first case is an 81-year-old gentleman with diabetes and ischemic heart disease. This patient was an aspirin. He had a fall and then developed right acute subdural hematoma. His preoperative GCS was E4, V2, M6, and he had left hemiparesis. Okay, so this is his preoperative CT scan. You can see a thick subdural hematoma, an acute one on the right side. Okay, this is the skin incision. You can see it's quite small. Okay. Okay, the dura has been opened. That's the membrane. So you cut it open and see the clots. So you evacuate it. So this is the endoscopic view. Okay, that is the malleable suction cannula. So we try to evacuate as much as possible. Sometimes the clots are quite thick and solid, and the suction may not be good enough to remove it. Sometimes you can use a forceps to remove it. Yeah, that's a bleeding point from the cortical surface. A lot of patients who have these acute subdural hematomas in the elderly actually don't develop it due to tear in the bridging vein. A lot of them actually has a bleeding point from the cortical surface. So see, we find them and then we just bust them with the bipolar. You can see that the space that there is not much, okay? So, but that's why the endoscope is so beautiful. In these tight angles, you can see everything you can inspect till the end of the site. Okay, so this was a post-operative scan. There is still some residual, but definitely the brain is more lax, and most of the acute subdural has been removed. So for the next case, another case, 69-year-old gentleman, ischemic heart disease and heart failure. Patient is on clopidogrel. Patient has a right acute subdural hematoma. His pre-op GCS was full. Okay, so this is his preoperative CT brain, about 1 centimeter clot. So this is skin incision, S-shape, craniotomy. Cut the dura in a cruciate manner. Remove the initial clots. You can see that there's actually not much space between the brain and the dura. So this is sucking up again, the clot. So a lot of times the remnant of the clot is on the dural surface because of the angle of the suction. So sometimes the remnant is there. It's easier to reach the cortex of the brain instead of the dura. Okay, so you just remove patiently. So you inspect one quadrant by one quadrant, and you see post-operatively, the brain is actually sunken. It's far from the dura. So we place a drain, most of the time, a passive drain, and we close in the usual manner. Okay. So post-operative scan, showing good evacuation. Okay, so let me share a little bit on the Fujita's experience on acute subdural hematoma cases. So these are just cases which I managed to get from 1 year ago until now. So a total of 7 cases. They're all elderly. The youngest is 56 years old with leukemia. 4 of the patients were on antiplatelets. So most of them had improved after the surgery and did well, except one who died, patient number 3. This patient actually developed a very bad cerebral edema and another bleed on the contralateral side, unfortunately. So what do I think we need for future studies? I think we definitely need prospective trials, ideally randomized trials, to compare craniotomies versus this method of removal, but not for all patients, for the elderly population. And maybe better objective selection criteria. Now we are using age and some subjective ways of deciding. Maybe we can use a CT criteria on how thick the clot is or how bad the cerebral atrophy has to be before we can employ this method safely. And comorbidity scores would help. You can use KPS, the Charlson Comorbidity Index Clinical Fatality Score. These scores maybe can help us to decide whether these patients should actually undergo any surgery at all, or whether this subset of patients would actually benefit from endoscopic instead of doing the conventional craniotomy or craniectomies. So in conclusion, endoscopic technique for evacuation of acute subdural and subacute subdural hematomas is at least not inferior to craniotomies for now in terms of mortality and functional outcome. I hope in the future there's ways to prove that it may even be superior for the elderly population and those with cerebral atrophy. These are my references. Thank you very much.
Thank you so much, Dr. 𝒀𝒐. And may I also congratulate to your presentation and also Fujita's team for this innovative method. I think this is quite innovative, and it really bridged the gap of our neurosurgeon in handling acute subdural hematoma in the octogenarian or geriatric patients in neurosurgery. It bridged the gap that for the patient that neurosurgeons usually don't want to operate. And I think this is quite an important method or study that we should consider further investigate. So my first ask the comment from the chair, Professor Arian.
Dr. 𝒀𝒐, thank you so very much for bringing and sharing with us your experience. Wonderful.
Thank you.
I was in awe with your points, very, very important points that we don't have currently definitive criteria in the selection of our patients for either, not necessarily for your technique, but in general for us to decide when to perform the surgery. And I encourage you, and I hope to soon see a work published by you and colleagues in that area. It leaves open spaces for us to learn more and to do better. We owe it not only to our patients, but to our mentors who brought us to the level and the challenge of learning how to do better. Do you foresee in the near future any movement toward the direction of you putting some scientific work together? You laid down wonderful points. We are still behind the two-decade-old advancements that have never made a change better than what we have. But so there is room to move forward. Are you planning something, maybe starting at Fujita and then soon publishing any work, or?
Yeah, there's nothing planned yet, but after preparing for this presentation, yes, there is that urge to do a study. And I think, like you said, the ideas have already been laid out, and hopefully we can come up with something soon.
Well, best of luck on that end, and good luck with your time at Fujita.
Thank you.
And thank you so much, Professor Arian. So how about, may I also invite Professor Oliseng for your opinion on this method for endoscopic removal of acute and subacute subdural hematoma.
Thank you, Ben. Dr. Sam, my congratulations. The topic is very controversial. It's not easy to be critical, but I have some critics and some discussion about this presentation. Please accept it as a basis for further development of your study.
Yes.
So first of all, you showed the cases with acute subdural hematoma in elderly patients with a minimal clinical presentation. So maybe there is a sense to wait in cases like this, not to do the urgent surgery. But you clearly demonstrated the prevalence, the evidence, how to say, the advantages of endoscopic technique in these cases. So from the one side, from the other side, maybe we can wait. So until we wait in elderly patients, we get the chronic subdural. In chronic subhumeral dural, I think that in the regular cases, this technique you showed, I think it seems to me too aggressive for chronic subdural in elderly patients. So in my practice, I use the minimum invasive, just passive drain, and that's all. It's a small borehole, small craniotomy, and all the passive drain, it's enough. But the next field for your investigation, I think, is recurrent chronic subdural hematoma in elderly patients. I think this is a field for your investigation because it's a really problem. It's a great problem, the recurrent chronic subdural. And my question is, how do you think, is it possible to find and coagulate the MMA during surgery of endoscopic surgery of chronic subdural hematoma? Because you know that there are some publications about the efficiency of embolization of MMA on the side of chronic with a good result. Maybe let us accept it vice versa and define the artery from inside and coagulate and maybe prevent the recurrences the next. So maybe this is my guidelines for you.
That's a good idea, but I guess it can be done, but it would be difficult because that narrow space and to locate it, and in the MMA actually bleeds quite fast. So for a endoscopic technique, I think it may be challenging, but yes, it's an idea worth exploring. Yeah, thank you.
Okay, thank you very much. Thank you for a very good topic and for quite controversial material, controversial presentation. Thank you very much. Thank you.
Thank you.
Thank you, Sam, for the presentation. I think Professor Perzard wants to ask a question. He's raised his hand. But before moving to the Professor Perzard, I think Professor Alexander was asking about the midmeningeal artery embolization for prevention of the recurrence. So I think we're also studying the options of midmeningeal artery embolization. Hence, there's a new study of the new vasculature of creating the recurrence of the chronic subdural. So, Professor Perzard, would you like to please unmute yourself and ask?
Okay, thank you. Thank you very much. Thank you, Professor Sam, for your presentation and achievement. It's really good work. But I'd like to know, in the case of, about acute subdural hematoma, usually accompanying with increased intracranial pressure and brain edema, especially in the head injury cases. And what is your advice for timing of operation and how to manage for the high intracranial pressure and also in the brain edema when you open in mini-invasive craniotomy and maybe it's push the brain and don't allow you to evacuate the hematome. How to manage this to evacuate endoscopically this hematoma? Thank you
so much, Professor Perzard, for the question. For endoscopic evacuation of acute subdural hematoma, I would say that for now we are limited to in patients which are only suitable for this. That's why the selection criteria is important. In patients in which we expect there to be a lot of brain edema, or we expect the brain to swell, especially if they have signs of herniation or very low GCS to begin with, these patients are actually not very suitable for this technique. And if you go on and do a small craniotomy, like I said earlier, that you actually may do more harm because the brain will just herniate through that small craniotomy and the brain gets, the blood supply gets strangulated through there. And you won't even be able to put in the scope, not even a short while. So I don't think at this moment in cases where there's very bad herniation, very bad cerebral edema, and the brain bulging out with very high ICP. I don't think there is a way we can actually use this endoscopic method for now. Yeah, hope that answers your question.
Thank you. Thank you very much.
Thank you, Sam. There's also, we have a few questions in the chat box for you. So Dr. Beck started with a question about the suitable cases for this procedure. I think you've just answered this question, and he asked about the comparative study between conservative and endoscopic evacuation and this group of patients. His second question is, are any patients treated in this series needed a decompressive craniotomy? His third question is, do you think this technique is good for extradural hematoma?
Okay, Mr. Lau Big Liang. Okay, let me try to answer his first question. I just want to know this procedure.
The first was comparing conservative to endoscopic evacuation.
Ah, yes. So, okay, this is a controversial topic to answer. Like I said at the beginning, there are three ways that people may manage this. First is totally do not do any surgery, do not offer because of the age and the comorbidities, and we just tell the family, you know, we are sorry, that's about all we can do. The second is to follow strictly the guidelines by Brain Trauma Foundation, in which they mention, regardless of the GCS, as long as it's 1 centimeter, regardless of the age, regardless of everything, go in and do the craniotomy and the craniectomy, as long as it's 1 cm or more than 5 millimeter shift. So the other part about conservative and then waiting until later on for it to turn chronic, in which I would say in my own country, we practice that a lot, and we end up doing burr and drainage. However, in this period of 2 to 3 weeks, while waiting for the clot to turn chronic, patients can suffer from complications. And in fact, there are a few papers I went through, and they said that about 20 to 30% of acute subdural hematomas actually expand in this period of 2 weeks. Other than this expansion and possible deterioration in these 2 weeks, meaning you would need to keep a close eye on these patients for that period of time, they can also develop epilepsy and seizures, in which the GCS may fluctuate. And from all these complications, they may end up developing pneumonias, orthostatic pneumonias, because maybe they don't eat well, they don't walk well during that time. And to add on to that, in this waiting period of 2 to 3 weeks, if they have antiplatelets or anticoagulants, you would have to stop the antiplatelets and anticoagulants for that long a time. And of course, they may develop some complication. For example, if you have the mitral valve stenosis or something and they needed their warfarin, they may get complications for that during that time. So this is something subjective, and of course, at this moment in time, we don't have any clear evidence to say which would be a better way of approaching these patients, whether to go in quickly and evacuate the clot as soon as we see them, or wait till they develop further symptoms and wait another 2 to 3 weeks and do a burr hole and drainage. I think that is definitely room for research there. So second,
did any case need the decompressive craniotomy?
Yes. Yes, that patient that died actually had a decompressive craniectomy, but unfortunately, with the initial GCS of presentation was already low, so patient didn't do very well at all, and the contralateral side developed another intracranial bleed. Yeah, so that patient needed EDH, extradural hematoma. Yeah, I have not experienced using the endoscope or gone through using endoscope to evacuate the extradural hematoma. But for extradural hematoma, I think the key is you need quite a wide exposure. I think like what Prof. Kishida mentioned just now, these are the subset of patients where the lesion is on the surface, and it would be best if you evacuate and cauterize the bleeders. And the main thing to prevent rebleeding in extradural hemorrhage is tenting. So I don't think it will be easy to do tenting if we just do a small craniotomy for extradural hemorrhage. Yeah, but I think this needs to be further explored. Hope that answers your question, Mr. Lau.
And there's also another question in the chat box from Masanji. He's asking about which approach do you think has higher recurrence rates?
Which approach you mean between craniotomy?
Between endoscopic and the basic surgical craniotomy operation.
Yeah. Don't have that much of data. In fact, the papers that you have I have gone through hardly had any long-term follow-up. So from those which actually shared their data, the cumulative incidence of rebleeding was very low, 3.5% for the endoscopic site. I'm not sure about the craniotomy site, whether that is any better, but I think from both sides, there will always be a risk of rebleeding for many factors, and also maybe it's surgeon based and the surgical technique. Yeah, I think more relevant would be the amount of residual after the evacuation.
Last question in the chat box, and then we go to Dr. Ben because he has his hand raised a long time ago. The last question in the chat box is about the subdural membrane with acute clots.
Yes, okay, very good question. This actually extends to the indications for endoscopic surgery for chronic subdurals, because usually the chronic subdurals will have these membranes. But then again, of course, chronic subdurals can have acute subdurals on top of the chronic subdurals. And of course, when you have these membranes, it will be good, you can go in and cut the membranes and how to say, reduce the compartmentalization and allow for better drainage. And studies have actually shown for chronic subdural hematomas, this technique of using endoscope to remove the membranes actually reduce recurrence for chronic subdurals. Yes, so you can do that the same if you see the membranes. Hope that answers the question. Thanks.
Dr. Ben?
Yes, hello, and thank you again for this wonderful lecture. And as mentioned by Professor Lorenzo, is still controversial topics. So I look here, I see Professor Kishida is still here, and he has mentioned, as we can appreciate from the last lecture, he's also quite an expert in endoscopic surgery. So may I firstly ask about Professor Kishida's your opinion towards this method about the endoscopic evacuation of the acute and subacute hematoma?
Thank you, Dr. Samuel and Ben-Nug. And sometimes I also perform the hematoma evacuation for acute or subacute subdural hematoma. Key points of this surgery is brain atrophy and without contusion or severe edema. Your criteria is correct. And the size and the location of the craniotomy is also very important, because we have to stop the arterial bleeding directly by bipolar coagulator. So we have to predict the location of bleeding point preoperatively. And sometimes subacute hematoma is not so hard, but real acute subdural hematoma is sometimes very hard. So it's difficult to remove from small craniotomy. So especially in acute chronic subdural hematoma, you should not so only small craniotomy, a little bigger. You should to make a bigger craniotomy. Not so こだわらない。So maybe subacute hematoma with chronic subdural hematoma is you can perform the only 2.5 centimeter craniotomy. But for the acute case, you make maybe 4 centimeter, 4 or 4.5 centimeter craniotomy to stop the acute arterial bleeding and remove the hard clot. That's a comment.
Yes.
I have one question about the anesthesia. You performed under the local anesthesia, right?
Yes.
I performed this surgery under general anesthesia because elderly patient with head trauma consciousness level is worse and respiratory condition is not so good. So local anesthesia, under local anesthesia, elderly patient with dementia sometimes move, and it's very dangerous. And local anesthesia with deep sedation make respiratory condition deteriorate, I think. So I think conversely, general anesthesia is safe, I think. How do you think about it?
Yeah, I think in Fujita, most of the cases are done under local anesthesia. And yes, patients can move. We restrain them, and assistant can hold the head. And I think most of the times, the patient actually cooperate quite well with good hemodynamic control. And so far, I've not heard of any respiratory problems from there. But of course, there should be a low threshold if these patients can't tolerate the local anesthesia. They don't cooperate because of the conscious level, then yes, general anesthesia would be the next step to go to. Yeah.
Thank you.
Mr. Singh, can I also ask about the anesthesia problem? Just now, we mentioned about that the case would be performed under the local anesthesia. But in case, just in case, and you cannot stop the bleeding, and would there be a trouble if you are trying to convert it into a bigger craniotomy? Because at that time you might require general anesthesia. So how does the anesthetic support in your unit? So how would you talk to your how do you talk to your anesthetist for the potential problem?
Yeah, a good question. I honestly, I mean, the cases have not been done by me, but from what I gathered from the surgeons who did the cases, there has been no such instance. And if really there is a risk of that happening, then like what Prof. Kishida said, maybe it would be best to start off with general anesthesia. That's why I think the selection criteria is very important. We should try to select the best patients for this. We can't just simply take any patient and just, you know, let's try out endoscopy. I think we have to be very strict with the selection criteria to prevent all these complications. Yeah. Thank you.
Thank you so much.
Okay.
I think Atiq also wants to ask you a question. Dr. Atiq, are you there?
Okay, thank you, Dr. Sam, for your brilliant presentation. I am currently a Fujita Fellow doing fellowship under Professor Kato Sensei. Definitely, your top presentation has provided us some sorts for the YNS, how we can do this type of cases by minimal invasive procedure. So my suggestion would, should we do coagulation profile in all these cases, especially the patients who are getting antiplatelet or anticoagulant?
Yeah, definitely. I'm sure all patients should at least get their platelet count done and coagulation profile done. These patients, if let's say an abnormality is detected, of course, just like craniotomy, we should correct them as quickly as possible to avoid the clot from expanding. And once it's corrected, then we can embark on the surgery. Yeah. Does that answer your question, Atik?
Okay, thank you.
Okay.
Thank you again for your brilliant presentation.
Okay, thank you, Atik.
We also have Dr. Delshod from Uzbekistan. He wants to ask a question, I think.
Yes. Hi, everybody. Thank you for interesting presentation, Dr. Joe Sam. Have a question. Were there any cases that you, when you were operating, I mean, the team who were operating the acute subdural hematoma during their evacuation, and the patient's condition worsened, and they conversed it to general anesthesia? If there were so cases, and how many? And this is the first question. And the second is, do you have they used any material for protection of the brain surface, cortical surface, when they are using, when they are inserting the endoscope, the tip of endoscope, in order to not to avoid the cortical vessels, the cortex, and so on? Thank you.
Okay. So for the first question, these cases were not done by me, and but from what I gather from the surgeons who did it, no, there was no such instance. If the patient already required general anesthesia, they were performed under general anesthesia to begin with. Yeah. So for the second question, over here, no, we do not use any protective material from the entrance, as I did mention just now. No, we did not use any. Yeah.
Okay. Thank you.
Okay.
So anyone wants to have questions for our speakers before we start wrapping up?
Sam, I don't want to take it any longer, but it just goes to say how challenging topic that we sometimes consider simple it is. It has so much room for us to explore the inclusion criteria and application and contraindications, and how.
Professor Arian, would you mind approaching the mic a little bit? The sound is...
My apologies. Yes, thanks for noticing that. I missed it.
No,
I just wanted to say that I'll use the words of Professor Wozniak, this controversial topic that most of us in a way started when we were maybe year 1 or year 2 during a residency, how we developed our skills, but yet it locks into the paradigm of knowing the selection criteria for our patients. And I've seen so many cases of subdural, acute or subacute or chronic, and not two are the same. And combined knowledge of our colleagues, we know that not two cases are the same. So I will leave it to you with the very much interest for maybe you to explore the field and soon to bring us a paper that will include all those question marks that we had. Good luck on that end.
Yeah, thank you.
All right, thank you, Sam. Thank you, Professor Ari, for this last comment. I was just asking if Sachin is feeling a little better and wants to join us. Dr. Sachin?
Yeah, so I don't have any question. I think both the lectures were fantastic. I think Joy, Sam, you're doing great there.
Thank you.
He wanted to very eagerly come to Nagoya, and he's been chasing since the New Year. So I think you're happy and you're really doing good there. Try to learn new things. Endoscopy is definitely the future. People would want their skull not to be open big, and they want their skull to be open small. That is the basic thing. What patient wants and what is the best for the patient, what is the less harmful for the patient is what we have to do. So the best, and even the first lecture was definitely very good, Professor Kishida Sensei. It was wonderful. I would request Professor Yoko Kato to say a final concluding remark before we close and give us us some guidance about how to go ahead in future with the minimally invasive endoscopic neurosurgery. You're muted, Sanjay.
So, Dr. Sachin, please take care of yourself because you're very much important for ACNS. So, especially for the YNS, especially from Central Asia, are waiting for your more work. I think for YNS. I think both lecturers were very excellent, especially Kisa Sensei is expert on the endoscope. But he said he at the beginning is training the microsurgical, but I did so many microsurgical procedure, but I think endoscopic view and the microscopic view is sometimes totally different. So of course the training of the microsurgery is very important. But if you want to do the endoscopic surgery, you should start as earlier as possible, I think. So I think maybe the 2-3 years after or parallel, you should start the endoscopic surgery. And also maybe at the Kisa Sensei, he doesn't need anymore the microscope, I think. But he tried to do the endoscopic procedure. He does make effort, I think. And second speaker, Dr. Joe, thank you very much for a nice presentation. And Dr. Dilshot, he asked us, we've not used a cotton putty because of the huge clot. So we don't need the cotton putty. And also, sometimes we do at the ICU or some ER if the cranial pressure is very high. So once we evacuate the clot as soon as possible, then we should think about if the patient needs some intubation, then we intubation, then to the general anesthesia. So just in case, just we can think about. So anyways, thank you very much for all speakers and also the good chair of the Arion as always. And also the discussant is Alexander and also the forward. So the especially Alexander, I think you should have as soon as the peaceful time in Ukraine. And
Thank
also and Dr. Ben, thank you very much for your nice the chair today. And thank you very much. So see you next time.
Thank you. Very good. Thank you very much.
Thank you.
Sachin, please feel better soon. I miss you.
Oh, I miss you too. I feel so much better to hear you. Your voice and your moderation is so much energetic. So I could not, although I was tired, I wanted to sleep, but I kept on hearing you and your comments. Thank you and especially Professor Alexander Wozniak. Your comments are always very important, especially for the young.
Thank you, Sachin. Thank you.
Thank you very much.
Sachin, take care and wish you good health.
Okay.
Bye-bye. Thank you.
Bye.
ありがとうございます。
ありがとうございました。
ありがとうございます。